Mr. Sushil?
Yes.
Yes, we are live, sir.
शुरू हो गया हाँ
Okay. Sushil, ready? All ready?
already online.
Yes,
sir.
we now we'll start. Okay. So good morning, everyone. And first of all, thank you joining on this Sunday morning. This is the first inaugural session on this mastery class in pediatric gastroenterology and hepatology module, and it is designed by Professor Dr. Sham Sundar Meena. And there are 12 classes on 12 Sundays, 9 a.m. to 10 a.m. And the all excellent faculty from across India is involved in this module. So today's topic is acid peptic disease and GERD. So I will not take much time. On the behalf of IAP office, I welcome you all faculty, all OB members, and all delegates. So I would like to invite Dr. Ajay Gupta sir to give a welcome address first, and then we'll hand over to the Dr. Meena.
Thank you, Dr. Dinesh. Good morning, all respected faculty and delegates. Wishing you all happy Republic Day in advance. We'll have crisp sessions designed by Dr. Shah Meena. We are joined by Dr. SMITA Malhotra, Senior Professor and Consultant at Apollo Hospital. And also the session will be chaired by Dr. Devender Srin sir, who is the Vice President North Zone IAP, and Dr. Alok Bhandari, Treasurer Central IAP. And session will be, expert will be Dr. Sufla. I request Dr. Shah Meena to please introduce the faculties.
Good morning to all. Very good morning to Central IP representative Professor Devender Sarin sir as a Vice President North Zone. Dr. Alok Bhandari, Treasurer Central IIP, and good morning to our Delhi IIP representative, President Sahab and Secretary Sahab and all EVs. And thanks to my all delegates as well as faculties, they showed a lot of the interest in this program to make the successful, and that is not a one-man effort, that is an entire team efforts. Behind that, we trying to make the successful e-master classes, as we have the previous experience with during my secretaryship and during my along with my president, we did a lot of the e-master class, and we get the very positive response, and we get a lot of the feedbacks. On keeping the mind of that feedback, we day by day we trying to improve our quality of our master classes. Now in today's session, that session chaired by the Dr. Supla Saxena. Dr. Supla Saxena is senior pediatric gastroenterologist currently working in Manipal Hospital as a head of the department. In today's our speaker is well-known personality, Dr. SMITA Malhotra. Ma'am is working as a senior faculty in pediatric gastroenterology department in Indraprasth Apollo Hospital. Ma'am have the numerous publications as well as various awards in the field of pediatric gastroenterology, hepatology. Ma'am the particular interest in the liver transplantation and handling the disease of the related to liver disease in children's. And we have the proud because ma'am belong to one of the hospital. They're the first liver transplantation in our countries. So over to Dr. Smita Malhotra to start the talk.
Thank Dr. Meena, please, we welcome Dr. Devender Srin sir, Vice President North Zone. He is ex-HOD of Government Medical College and Hospital from Udaipur, and he was the EB member from Rajasthan of Central IIP in 21 and 24. I request Dr. Devender Srin sir to please say a few words. Sir, please unmute.
Good morning, all. A very, very happy Sunday. I know you daily people, everyone is very health conscious. So it is a in the morning yoga and walking, and then this gastro seminar, this is webinar, the gastro webinar. So I wish you all the best, my dear Dr. Alok Bhandari sahab in his absentio. Then our EB members, Dr. Mukesh Dhankar, Dr. Pankaj Garg, and Dr. Ajay Kumar Gupta, the president of IAP Delhi, and Dr. Dinesh Goel, secretary IAP Delhi, and then Sham Meena, he's the program coordinator, and then our, I will say, very eminent speaker, Madam Smita Malhotra, and the chairperson, Dr. Sufla Saxena. a very good morning to you all the participants. I will just clap for the participant, 200 participants. It is wonderful on the Sunday morning. This shows that how much enthusiasm they all have got. You all are our strength. We will all work together. So every IAPN is the strength of the IAP. So once again, wishing you all the best. You have made a calendar of every monthly you will have every monthly for 12 months, 1 year.
Yes, sir. Yes, sir. We'll
One
keep
year
on
program.
having.
So whole 1 year program. This is a very well planned. I wish you all the best. Any work, anytime for me, you are always most welcome. And once again, because I have to go for the Rotary seminar also, so I'll take your leave from you. Okay, thank you very much. And once again, all the best, all the best.
Thank you so much,
Thank
sir.
you, Dr.
Thank you
Serene,
for
for your
joining and
blessings,
sparing
sir.
time. Thank
Dr.
you, sir.
Mukesh, Dr. Pankaj is also here. Dr.
Welcome, Dr.
Dr.
Mukesh
Pankaj,
Dhankar, sir.
please say a few words.
Yeah.
Yes,
So,
sir.
good morning, delegates. So, it's time for some good academic session in the morning. So, starting from Gastro and starting from Dr. SMITA Malhotra, is a proud privilege to say that Dr. SMITA has been very active in gastro field at Apollo Hospital, and she has been a student of Gangaram Hospital. So, I feel doubly proud that she's doing so well in her field, and I wish her all the best in her future endeavors. And same to IIP Delhi and CIP. We are so academically oriented, so we do everything. We are fitness freaks also, we are academic activities also, and we socialize also. So that is the spirit of IIP. Let us be together. Let us remain united. Keep on encouraging each other, not criticizing, but helping each other to develop your own personal skills as well as academic skills. With these words, over to Dr. Dinesh. Thank you so much.
Thank you, sir. One word, sir, from Dr. Mukesh Dhankar, sir.
I would not come in between this session, so let's start this session. That's my humble submission.
Thank you.
We
Thank you so
also
much,
welcome
sir.
Dr. Sunil Gupta and Dr. Shelja. Please keep on answering these questions in the question answer box. I request all delegates to put your queries in the question answer box.
Yes. Yeah.
Start, ma'am, please.
Yeah, please, ma'am. Start.
Very good
I
morning to
request
all of
everyone
you.
to keep your mic on mute.
Very good morning to all of you. And I really thank the IIP Delhi for giving me the opportunity to do this session and to be the one who starts it, to set the opening meetings. And I hope I can set a right benchmark and do justice to the task that has been granted to me. And I'm very proud to have my teacher, Dr. Pankaj Garg, here, and seeking your support and blessings always, sir. So it's a these are two very common topics which we deal in our practice every day. And it's, I think, rather difficult to do justice to both of them in one presentation, but I'll try to do it. I have not made it a very theoretical presentation. It's a very practical approach-based presentation. So we'll start with acid peptic disease, and it's classified into peptic ulcer disease, stress-related mucosal injury, and gastroesophageal reflux disease also as a part of it. So the various case scenarios, we present a 14-year-old boy, epigastric pain for 4 months, relieved by antacids, worsens soon after food, associated with nausea and sore belching. There is no history of hematemesis, melena, NSAID use, or any chronic illness. Growth is normal. There is just mild pallor, mild epigastric tenderness, and rest of the examination is normal. And this is when we can see that the history is very classic, typical epigastric pain. And we find a 1.5 centimeter gastric ulcer on lesser curvature with surrounding gastritis. And the RUT, which is a rapid urease test, is positive. We do a biopsy, which is suggestive of H. pylori associated gastric ulcer, and then an eradication therapy is done. So this is very common. We see it very commonly. And the less common presentation which we see, when does an ulcer turn catastrophic? Now, this was a 15-year-old boy who presented with sudden onset of severe abdominal pain for 6 hours. The pain was acute and sharp, started from epigastrium and rapidly spread all over the abdomen, associated with non-bilious vomiting, abdominal distension, and there was no history of any trauma. There was a background history of recurrent epigastric pain for a few months, used to increase on empty stomach, partially relieved by antacids. There was no history of NSAID intake. History of poor appetite and weight loss was present. On examination, child was toxic, anxious, he had tachycardia, he was hypotensive, there was generalized guarding and rigidity, bowel sounds were absent. His counts were high, CRP was high, X-ray abdomen showed free air under the diaphragm. and USG abdomen showed free interperitoneal fluid with internal echoes. So this was bowel perforation with peritonitis, and emergency laparotomy was done. A 0.5 centimeter perforation was found on the interior wall of the first part of duodenum with purulent peritoneal contamination. Perforation was closed using Graham's mental patch. Post-op H. pylori was positive. Eradication therapy was started. So these are rare presentations, but they are not that rare, especially in setups which deal with ICUs, where we have sick children who go into hypotension, they have ischemia, and they have stress ulcers. We have lost one post-transplant kid to a duodenal ulcer bleed because the child was in another country, and by the time the symptoms developed and they could come, he had developed catastrophic bleeding. We presently have a child in our ICU who was operated last night for a perforation, and this child presented with acute liver failure, which was managed conservatively, and then developed abdominal distension, and the CT done yesterday showed a pneumoperitoneum. So in these presentations, the first case is the routine presentation, which you will see very commonly, and the second case is the presentation which will happen off and on, but which is very catastrophic and needs a high index of suspicion. So peptic ulcer disease is characterized by discontinuation in the inner lining of the GI tract because of gastric acid secretion or pepsin. Layers involved are mucosa, submucosa muscularis. Common sites are the stomach and the proximal duodenum. Less common sites are the lower esophagus, distal duodenum, and jejunum. It happens because of imbalance between acid secretion and gastric mucosal defenses. So the aggressive factors, presence of acid, presence of pepsin and bile, and the defensive mechanisms are secretions of mucus and bicarb, prostaglandins, blood flow, restitution, and regeneration. So whenever we have this imbalance, we have problems. So this is a busy slide, pathogenesis of peptic ulcers. So aggressive forces include H. pylori, NSAIDs, aspirins, corticosteroids. Smoking and alcohol in adolescents are becoming common, though in younger children they are not the etiological factors. The mucosal defense forces which we normally understand are the surface mucus secretion, which forms a barrier, the bicarbonate secretion into the mucus. This is usually hampered by rampant use of PPIs. So mucosal blood flow, as I said, which happens in sick children, apical epithelial cell transport systems, regenerative mechanisms, and the elaboration of prostaglandin. Diseases which could be associated could be cirrhosis, renal, in fact, any systemic illness which causes stress, chronic renal failure, Zollinger-Ellison, we know, hyperparathyroid, all these conditions. So you will have increased gastric acidity and peptic activity, impaired defenses will, and then with background of ischemia, shock, stress-related factors sometimes, delayed gastric emptying, duodenal acid reflux, and decreased retrograde motility. These are all factors which will lead to an imbalance and lead to peptic ulcers. The commonest causes which we see are H. pylori infection, NSAIDs, and medications. Zollinger-Ellison, malignancies, stress, viral infections, vascular insufficiency, then radiation, Crohn's, and chemotherapy. There are the rarer causes. What are the common clinical features? Epigastric abdominal pain and bloating, abdominal fullness, nausea, and vomiting. Red flags are progressive dysphagia, weight loss, refractory iron deficiency anemia, GI bleed, and family history of upper GI malignancy. So the most common presentation is, we all know that abdominal pain is very common in children. So vague abdominal pain, functional abdominal pain is very common, but we should always remember that that is the pain which will be periumbilical. And that is a dull kind of pain. This is a shooting kind of pain in the epigastrium, and the child will be able to point a finger and tell you that this pain is in the epigastrium. Sometimes you will have also a retrosternal pain. So these are the typical features. Now there is a lot of confusion about H. pylori, how to detect H. pylori, how to treat H. pylori. So a few slides about guidelines of H. pylori related peptic ulcer, because that is one of the commonest indications we will see. So first is, whom do you need to investigate and whom you don't need to investigate. So you investigate all children with gastric duodenal ulcer erosions. So you do an endoscopy, you find erosions, you find ulcers. These children have to have a gastric biopsy for H. pylori and another test for H. pylori. Children with iron deficiency anemia who are not responding to iron therapy, children with family history of gastric carcinoma and first degree relatives, these children will have a non-invasive test, not an upper GI endoscopy. Whom not to investigate? Children with functional abdominal pain. Now, functional abdominal pain criteria are very clear, And the Rome 4 criteria, that is the, though we are just waiting for the Rome 5 also, they will be coming soon. But the major improvement in the Rome 4 criteria over the Rome 3 criteria was that the need for a lot of evaluation and testing was done away with. We have set criteria, and if those criteria are met, you just need to take a good history, and without any investigations, you can make a diagnosis of functional abdominal pain. And all children with functional abdominal pain is also divided into categories. You have IBS, you have functional abdominal pain not otherwise specified, you have abdominal migraine, so you have peptic, epigastric, those dyspeptic pain. So these are you can, on the basis of the symptoms, you can classify which type of functional abdominal pain it is. And if it is not fitting into any of these, then you can label it as functional abdominal pain not otherwise specified. But every child with functional abdominal pain does not need an endoscopy, does not need a CT, and does not need any invasive tests. So children with IBD, celiac, and eosinophilic esophagitis, these are children for whom you don't need to go out and look for H. pylori. If incidentally you find it, because you are evaluating them for these diseases and biopsies are taken for diagnosis in these diseases, in that case, a decision to treat can be taken on a case-to-case basis, but actively looking for H. pylori in these patients is not required. Any child with growth failure, short stature, or patient with chronic ITP, H. pylori, looking for H. pylori and treating is not required. Now, in chronic ITP, this guideline is in contrast with that for adults. In adults with chronic ITP, there are recommendations to look for H. pylori and treat it. But in children, we don't have enough data to support it, and it is not recommended. Diagnosis is invasive by an upper GI endoscopy and non-invasive by a urea breath test and monoclonal stool antigen test. Upper GI endoscopy is gold standard, and you need to take 6 gastric biopsies, 3 from the corpus and 3 from the antrum. So most of us will not take the trouble of taking 6 biopsies, but that is what we should always remember, that you may not be able to pick up the H. pylori if you just take 1 or 2 biopsies and you don't take both from the corpus and the antrum. The tests which we need to do, you need to do a culture and an antibiogram. Normally, we are not doing antibiogram that much in our country, but ideally it should be done. Histopathology, molecular tests, and rapid urease tests. There are limitations. If you have an active bleeding, you might get a false negative result even if there is an H. pylori infection. And the other confounding factor is whenever we have children with abdominal pain, even functional abdominal pain children are on PPIs. So if you have a typical child with epigastric pain, ideally you will need to stop PPIs for 2 weeks. Sometimes the symptoms may not warrant that you may not be able to stop PPIs for 2 weeks. In that case, you can shift to H2 receptor antagonists and then do an endoscopy. And if your child is on antibiotics or bismuth salts, they should be stopped for at least 4 weeks before you do an endoscopy. Coming to the non-invasive tests, the urea breath test, patient is asked to swallow a solution of labeled urea, and H. pylori produces urease, which splits the urea into the 13C carbon urea into 13 carbon dioxide. They breathe into a bag and then lab measures it, and a significant increase indicates H. pylori. The stool antigen test is a monoclonal antibiotic body-based test. It is better than rapid immunochromatographic version. It is a fast result, and it should not be done during diarrhea. When to use non-invasive tests? One is when you have done a treatment for H. pylori, no significant resistance is there. Sometimes you give the full treatment course and still you are not able to eradicate the H. pylori. So to test for the eradication, at least 6 to 8 weeks after completion, you do this non-invasive test, the stool antigen test or the urea blood test, to see whether the H. pylori has been eradicated or not. And secondly is, as I had mentioned earlier, if you have a first degree relative with gastric malignancy, then as a screening test, these non-invasive tests are done. What are the treatment guidelines? Now, clarithromycin antimicrobial susceptibility testing is to be done to guide the eradication therapy. We are not usually doing it, but ideally it should be done. And if it is not done, then clarithromycin should not be used as first line for treatment of H. pylori eradication. Antibiotic sensitivity testing guided triple therapy using a high dose PPI, high dose amox for 14 days is recommended. I have seen a lot of people prescribing H. pylori eradication for 5 days, 7 days, 10 days. So that is not right. They need to be treated for full 14 days. And during the eradication phase, their GI symptoms might sometimes paradoxically worsen, because with these medicines, they can have further, regurgitation, bloating, abdominal pain, cramping, sometimes vomiting, sometimes diarrhea. So we usually now add a probiotic along with that, but it has to be done for full 2 weeks. And if antibiotic sensitivity is not done, then a bismuth-based quadruple therapy is recommended, in which you give bismuth, PPI, Amox, and Metrogyl for 10 to 14 days. Antibiotic sensitivity testing for is not recommended for Metrogyl because the results are inconclusive, and I've not seen anybody doing Metrogyl testing. So I'm not even sure it's available. So susceptibility testing for clarithromycin, if you can do the testing and it is the child is sensitive, then you give PPI, Amox, and clarithromycin, which is first line. If it is resistant, then you give quadruple therapy, which includes bismuth. If you don't have sensitivity testing, then directly go for the PPI, Metrogyl, Amox with bismuth therapy. Rescue therapy is in case of persistent H. pylori infection. Even after completing therapy, rescue therapy is to be given, and assess possible failure reasons as non-adherence, inadequate dosing, treatment non-tailored as per antibiotic sensitivity testing. Mind you, here, before making a diagnosis and prescribing an H. pylori eradication therapy, you need at least 2 tests which are positive. Either you have a histopathology and another test like an RUT. Just doing an RUT, finding a positive RUT and treating is not recommended. So if we have, this is for the rescue therapy. So if you have clarithromycin susceptibility and you have already treated with amoxicillin and clavulanic acid, then you give amoxicillin and Metrogyl. If you have already treated with amoxicillin and Metrogyl, you give amoxicillin and clarithromycin. If it is unknown or susceptibility is not there, then you have to give a quadruple therapy with amox, Metrogyl, PPI, and bismuth. What are the future directions? Potassium competitive acid blockers, they have already been approved in Japan and USA. Development of vaccine is coming up. There is a lot of thinking about just finding H. pylori and then treating it to be discouraged, because many times I have also seen in my clinical practice, like if we have a Crohn's disease patient or we have something, we take gastric biopsies and we find a few H. pylori, occasional H. pylori, and you'll have a mild gastritis. So these patients do not need to be treated, and we have many times left these patients. When you find, even we have found H. pylori, we have not treated. Why? Because it is being shown to have a preventive role in some conditions. In bronchial asthma, it has a preventive role. In celiac disease development, it is being postulated, though we don't have data to prove it. Even for eosinophilic esophagitis and for immune modulated diseases like Crohn's and IBD, H. pylori may have a protective role. So just eradicating it, if you don't have any ulcers, erosions, or typical symptoms, it's not to be done. Many times you're doing an endoscopy for celiac disease, you want to take duodenal biopsies, you see some redness in the antrum, and you take biopsies and find some H. pylori. So that is not the way to treat it. H. pylori is not to be blanketly treated. So better markers to decide who needs eradication therapy are also being evaluated. Now coming to gastroesophageal reflux. So here, my first case is a 6-year-old boy who presented with history of recurrent vomiting, non-bilious, and burning sensation in upper abdomen for 3 months. This increases after meal at night. History of regurgitation of sour tasting fluid in the mouth is there. There is no history of fever or hematemesis, weight loss, and symptoms are typically increased after spicy food. Vitals stable, weight and height 25th percentile, mild posterior pharyngeal erythema, and systemic examination within normal limits. Baseline labs normal. Upper GI endoscopy shows erythematous distal esophagus with erosions. Biopsy features consistent with reflux esophagitis. 24-hour esophageal pH monitoring, increased acid exposure. So diagnosis, gastroesophageal reflux disease. Another is a 13-year-old child who presented with 3 to 4 episodes of hematemesis for last 1 to 2 months. History on and off pain abdomen, sour taste in mouth. Stable, height and weight between 5th to 10th centile, mild pallor, systemic examination normal. Labs hemoglobin is around 7. And when you do an upper GI endoscopy, you find reflux esophagitis with hiatus hernia grade 2. So here you can see the hiatus hernia, and you have significant lower esophageal ulcerations. Now these ulcerations can sometimes extend up to the upper end of the esophagus also. And sometimes I have seen, you may find typical features of the longitudinal streaking of eosinophilic esophagitis also. And clinically, it might look that this looks just like eosinophilic esophagitis. Sometimes making a differentiating between eosinophilic and reflux might be difficult, and that is why for the treatment of eosinophilic also, first we always rule out reflux esophagitis by biopsies and by looking at the response to acid suppression and PPIs. So definition, gastroesophageal reflux is the passage of gastric contents into the esophagus with or without regurgitation and vomiting. So this might be normal physiological passage which settles on its own, does not cause discomforting symptoms. But when it leads to troublesome symptoms that affect daily functioning and cause complications, then we label it as gastroesophageal reflux disease. And we call it refractory when it is not responding to optimum treatment after 8 weeks. The pathogenesis would include, underlying mechanisms would include anatomical defects. If you have a hiatus hernia, you have immature esophageal anti-reflux barrier. If you have motility issues, esophageal or gastric hypomotilities, which happens in patients with esophageal atresia, after the surgery, they will have motility issues, and reflux is very common in these patients. In eclasia patients, in patients with cow's milk protein allergy, almost 15 to 20% overlap is there with reflux. And decreased saliva production and supine position do contribute. And if you have a esophageal mucosal defect like eosinophilic esophagitis or eosinophilic infection, and if you have upper esophageal sphincter dysfunction, which will can lead to extra esophageal or respiratory manifestations. So with reflux, most common symptoms will be spitting or vomiting. There will be refusal to feed. The child will arch, smaller babies, they will arch towards while feeding. There will be feed refusal. They'll have failure to thrive. They could just have subtle anemia. Then they could have respiratory symptoms. Now, these respiratory symptoms could just present as repeated mild respiratory infections because of microaspirations to severe symptoms like apnea, stridor, severe wheezing. So it has a full spectrum, and they can present in this way. And obviously, when you have severe ulcerations, you can present with hematemesis and bleeding episodes. So clinical features typically in adult are retrosternal burn, regurgitation, dysphagia or dinophagia, chronic cough, hoarseness of voice, weight loss, and GI bleed. In toddlers, they are regurgitation, recurrent vomiting or regurgitation, refusal to feed, epigastric pain or non-specific tummy pain. They'll be irritable. Then there will be sleep disturbances because reflux increases when they are sleeping. Cough, recurrent lower respiratory tract infections, and failure to thrive. And in infants, again, recurrent vomiting, regurgitation, back arching, which is and Sandifer's manifestations like Sandifer syndrome, refusal to feed, poor weight gain, apnea, wheezing, stridor, and recurrent lower respiratory tract infections. Diagnosis. Ultrasound will also show you the lower esophageal sphincter and the stomach anatomy, the barium swallow, endoscopy, pH monitoring, esophageal manometry. Now, electrogastrographs are also being done, though we are not doing here, and biomarkers are also being developed. So this is a little busy slide, but it just shows the main approach that if you have clinical manifestations of suspected GERD and alarm features are present, work up and first manage, make sure that you are not dealing with any mimics. If there are alarm features in infants, if there are GI symptoms and signs, first thing is to avoid overfeeding, because in smaller babies, one of the more commonest symptoms is the mother is just overfeeding. So avoid overfeeding, or try thickened formula, or try treatment of CMPA for 4 weeks. If there is no improvement, refer to a specialist, or you may try to treat with PPI for 4 weeks, and then you may go in for pH monitoring or endoscopy and biopsy. If you have extra GI symptoms, then I think or in children or infants, then a pH monitoring or a endoscopy and biopsy should be done. In fact, both should be done, but usually the pH monitoring and manometry studies are not available everywhere, though now we have a lot of pediatric GI specialists in many tier 2 cities also. So endoscopies are more accessible and more easily available compared to manometric studies. So if you have positive here, then treat with a PPI for 8 weeks. If there is no improvement, then you may give a high dose PPI or other medications and sometimes even go for surgical intervention. We at any step, if we find that we are off track, we'll always rule out GRD mimics. In children, if you have typical symptoms, you may just give a PPI course for 4 to 8 weeks without going in for an endoscopy also. And in high-risk children, like the children who have had esophageal atresia surgery post-surgical correction, or you have neurological deficits, or if you have preterm infants, then the manometric studies would come first along with endoscopy and biopsy. And then based on the results, PPI and prokinetics for 4 to 8 weeks. And if there is no improvement, then go in for motility testing and impedance pH metry and further studies. So ultrasound will assess anatomy of the esophagus and real-time reflux. It's sensitive but not very specific, and reliability depends on individual's experience. Barium swallow can evaluate anatomical abnormalities. I would say when we have symptoms like vomiting and failure to thrive also, it would not be just barium swallow. We would like to do a barium follow-through, because sometimes these children can have malrotation also, which presents as vomiting, and you may diagnose it as reflux. So evaluate for anatomical abnormalities. Reflux can be observed. You should always, when doing the barium studies, always tilt the child head down and take a film, definitely. Otherwise, you will miss the reflux. Poor sensitivity, and this test has a poor sensitivity specificity, and it is not very routinely. We do use it, but because we don't have other tests to be done so frequently. Otherwise, according to literature, it's not a very good test for the diagnosis. pH monitoring, or the routine pH monitoring only tests for acid reflux. The combined impedance, interluminal impedance pH monitoring will tell you about both acid and non-acid reflux, even gas reflux. And if now even combined video impedance monitoring is available, so this is the best, is the most superior. So in pH monitoring, acid reflux will be documented in all three. Non-acid reflux will not be documented by the pH monitoring. Gas reflux will not be documented by the pH monitoring. Bolus movement will not be documented. The other two impedance methods will give these results. Symptom correlation also is limited. And on PPI, you can't evaluate with pH monitoring. So these are the limitations of pH monitoring over the impedance monitoring. This is a pictorial representation of the pH monitoring. I think this is not for the pediatrician, so I'll skip that. So treatment, non-pharmacological treatment and pharmacological treatment. The non-pharmacological treatment is head position and transpyloric feeding. So though the guidelines say that the position does not make much of a difference and there are no clear recommendations for that, but a 40-degree reverse Trendelenburg position might help. And in smaller children, we always advise head elevation to prevent the reflux. Transpyloric feeding can help, but the problem is that the catheters get the tubes get displaced very frequently. But if you're able to do transpyloric feeding, it significantly reduces reflux episodes. Pharmacological treatment, PPIs, pro-motility drugs, esophageal mucosal protection, and probiotics. Surgical treatment, fundoplication, transoral incision, less fundoplication can also be done. I am not going into the details of the pharmacological treatment. If somebody has questions, I can answer them, because I think I just wanted to do it in time. And I would just like to introduce you to my book, in which we have written stories of, I have written stories of 25 children who underwent a liver transplant at our institute. Thank you. I hope you found this presentation useful.
Thank you, Dr. SMITA, for such a elaborative, discussion of peptic ulcer disease as well as reflux. Though these are very big topics to cover, the house is open for question. Before that, I would like to congratulate the entire IAP team, to putting this gastro module together, and especially Dr. Sham, because being a gastroenterologist, I see with the changing scenario, food habits, environmental factors. I think gastro diseases are one thing which are becoming really common in children, especially, recurrent abdominal pain and reflux. We are dealing in day-to-day life. And most of the time, pediatricians, what they see, they will never see the classical symptom as we describe in peptic ulcer. Children will never come like that. especially toddlers, they will always come with an non-specific periumbilical pain. Sometimes, bigger children may have classic epigastric pain. However, as pointed out by Dr. Smita, I would like to say that, manometry is not available. But mostly we go for an ultrasound scan, and then if the pain persists, we go for a CT. So in that case, whenever you are dealing with reflux symptoms, it's always better to do an endoscopy because, it gives you a better result, better picture what actually you are dealing rather than doing a CT abdomen. You saw that in these, symptoms, classical symptoms when child present with abdominal pain, um, and they will say they have chest pain or some sticking sensation in the throat. Uh, but most of the time, the modality of choice becomes CT rather than doing an endoscopy. And with so many pediatric gastroenterologists now available, I think that's a better modality of choice in terms of diagnosis and managing the child.
Ma'am, please stop sharing the screen.
Okay.
We welcome Dr. Alok Bhandari, sir, Treasurer Central IIP, and request him to please say a few words. Then we proceed.
Yes, okay.
Yeah, please. Good morning, friends. I'm sorry to interrupt Dr. Smita, but I don't know. But yes, it has been a great learning session in the morning today. And I compliment IAP Delhi for launching yet another e-class module. And my best wishes to all the participants also. And here I would just like to say that all the dear participants, please spread this message that IAP Delhi is always forefront of academics and learnings, and everybody should become a member of IAP so that they'll get messages appropriately of all our academic activities. And in this, under the leadership of Dr. Ajay Gupta and Dr. Dinesh Goyal, I'm sure this year you'll find lots of activities after activity, and everybody should join them in large numbers to enjoy the academics and the overall environment of strengthening the IAP functioning all over the country. Thank you, please. Thank you.
Thank you,
Good
sir.
morning,
Thank you, sir.
sir.
Thank you.
Alok Bhandari sir, namaskar. A
Anand.
person who is always inspiring and guiding. Thank you, sir, for
Yes,
joining.
yes.
Dr. Vishwanathan, sir, if you're there, please raise your hand. I also welcome Dr. Lakshikant, who is also again a faculty for our program. So, ma'am, please go.
Okay, sir.
So there are a few questions in chat box. Yes,
Before
Dr. Meena, sir.
Dr. Dinesh, before taking the question, as a being pediatrician, my question to Dr. Smita, ma'am, what are the things we should consider if we are the sitting in the OPD and child coming with the repetitive upper abdomen pain? What are the things that indicate the child should be taken consider for the gastroenterologist opinion?
Well, as a gastroenterologist, I'll say if any child has seen you twice for for abdominal pain, please send to a gastroenterologist. And I would
Because in the functional component is also very important thing in the GI.
functional is, I think, the most common. We all know that in abdominal pain, almost 85 to 90% is functional. And functional needs a very, it needs a very compassionate approach. For functional, as I mentioned during my presentation, on the basis of the criteria, you give them a positive diagnosis. So functional does not mean frivolous or fictitious. It is real pain, but it is not organic. It is not because of some abnormality in any in the physical mechanisms of any abdominal organ. So you give the parents a positive diagnosis, tell them the reasons, try to explore the factors which they are causing it. And I think early introduction of counseling sessions helps. Many children of my abdominal pain patients, I refer them to clinical psychologists very frequently. And we also need to talk to them to uncover the family dynamics and the school dynamics and lots of things. Another thing which is very common in abdominal pain is constipation. So even when you have constipation, even what I have seen in my practice is that because of delayed gastric emptying or whatever happens, the incidence of gastritis also increases in constipated children. There even reflux and bloating also increases. So looking for occult constipation is very common. That also we need to see. So for abdominal pain, it's just a good history and a good physical examination. I'm very thankful to Dr. Sufla for raising this point about CT. For CT, for abdominal symptoms, CT has only very few indications. If you are suspecting a surgical cause like an appendicitis or a cholecystitis, you think you may have a something surgical, then obviously you will do a CT. If you have a pancreatitis, you will not do CT in mild pancreatitis, but if the symptoms are severe, and that also later on. We see so many patients coming in with a CT on day 1 or 2 or 3 of acute pancreatitis. So it has to be done later beyond day 5 so that we can have the full picture develop. And if you do it too early, the contrast which is given for CT, it will block the end capillaries and it will cause the pancreatitis to worsen. So degree of necrosis increases if we give the CT contrast too early. So pancreatitis, surgical conditions, or you want to do a CT guided some lymph node biopsy or some tumor biopsy, or if there is a history of trauma. These are the major indications for CT in children with abdominal pain. Otherwise, there is nothing that the ultrasound will not tell you. If you have done an ultrasound which is essentially normal, there is hardly any point in doing a CT.
So in the short, ma'am, any child have the recurrent pain abdomen or chronic pain abdomen with the unexplained history and examination, we should be considered for the more detailed evaluation
Definitely.
or along with the red flag signs.
One more point I would like to add, especially in toddlers, you see a lot of refusal to feed. Suddenly, parents coming to you, they say, Ki, my child is now not interested in eating, not interested in feeding. So that is one very important sign that you have to look that, okay, this is one additional feature that, we have to look inside or, explore further that what is the reason of this abdominal pain and refusal to feed.
And second,
I can't hear you, Dr. Menon.
what is the standard recommendation for the diagnosis of the H. pylori gastritis? However, you already told in your presentation, but we re-emphasize in the front of our audience is mostly pediatrician, because many times even in the gastroenterology they did some RUT test and on basis of they started the treatment without any symptoms.
Yeah, so that is not to be done. As I had mentioned that if you find an RUT, just an RUT positive, treating for H. pylori is not to be done. Sometimes I have seen even non-invasive tests being done, stool antigen being done, and then treatment being given. So that is not to be done. And you need 2 tests, and along with presence of symptoms, only then we treated.
So message here clear, no role of the diagnosis for the non-invasive test like the stool antigen test is totally discarded for the diagnosis of the H. pylori associated gastritis. That test might be help for the further clearance or treatment response to H. pylori bed regimen. Then third, what are the concept about the weight-based regimen for the treat the H. pylori associated gastritis? Because in the adult population, they have the fixed dose combination, but what about the pediatrics?
So I think in my practice, I follow the per kg the doses, that is better. The blanket doses are also there. We know that for metrogyl, clarithromycin, for amoxicillin, they have given weight based. You can follow that also. If you are like for clarithromycin, if less than 25 kgs, you give 250 mg, and if it is more than that, it's 500 mg. So similarly for metrogyl, less than 25 kgs, it is 250. To 25 to 50, it is 500. Above 50, it is 750. So you have these can be followed. I usually tend to follow per kg medicine ranges. We all know they are available for most of the PPIs. They range from 0.6, 0.7 to 2 to 3 mg per kg per day.
So message is simple. Up to the 18 year or up to the 35 kg weight, we try to follow the weight regimen rather than blindly. Then what is the role of the clarithromycin antibiotic sensitivity test? But because nowadays, even in the Indian studies from the PGI side, they said metronidazole resistance is also not uncommon in the pediatric population. So what you suggest? We should go blindly with if the sensitivity test is not available, we should go blindly with the bismuth based regimen, or we should think for the others?
See, as per the guidelines, what they are saying is bismuth-based regimens should be used. But in personal practice, I don't think many of our colleagues are doing it. At least I am not doing it. I can ask you and Dr. Sufla what you are doing. Ideally, according to guidelines, we should do sensitivity testing and then do it. Metrogyl sensitivity is not reliable also. Even if you are able to test, it is not reliable. Resistance definitely is there. So in ideal situation, yes, but I don't think we are using bismuth salts too much. What is your practice, Dr. Meena?
Definitely, you rightly said it's very difficult to manage.
Yeah, yeah.
And what is the recommendation of the minimal or maximum duration of the PPI in the H. pylori gastritis or acid peptide disease?
So PPI duration is 4 weeks. 2 weeks we give twice daily, and then for 2 weeks we give once daily.
So in the short, if the child is responded to PPI, at least minimum 4 to 6 weeks should be prescribed.
One question I would like to ask Dr. Smita in your practice, because usually I've seen children are not very compliant with clarithromycin because it has a very bad aftertaste.
Yeah.
So they usually prefer the quadruple or 3-dose regime with metronidazole is better tolerated, especially for 4 weeks duration.
Mhm.
So what have you seen that same kind of response in your children as well, with
No,
clarithromycin and metrogyl
So
suiting them better?
I routinely give a probiotic with this thing, and I use clarithromycin a lot. Though we are not doing the antibiotic testing, we are not even testing for after eradication. We are not doing the urea bread test to see whether it has been eradicated or not. Clinically, we are just following the symptoms. The child is well. We just don't do. We just follow that. But children, I would say, since it is a prolonged antibiotic course for 2 weeks, I add a probiotic. There are not clear much recommendations, but literature is coming in for use of probiotics with H. pylori. So I tend to use with a probiotic, and they do complete the regimens.
So message here clear. Definitely, one of our participant also are does any role of the probiotic to routine the management of the H. pylori associated gastritis. So definitely till the date that the evidence coming in the favor of the use of the probiotic, but we need the more evidence to include in the guidelines of the role of the probiotic for the management of the acid peptide disease. But till that, not a recommended.
Yeah.
Okay. And about the GRD. As a being pediatrician, how can we differentiate regurgitation and vomiting and gastroesophageal reflux and gastroesophageal reflux disease?
So as I had mentioned, for gastroesophageal reflux disease, you will have symptoms. You'll have failure to thrive. You will have dental erosions. You may have respiratory symptoms, or you may have pain, recurrent vomiting, large volume vomiting. So in typical, just regurgitation is basically harmless. It doesn't cause much difficulty. One thing which we have to think about is rumination is also very common. So rumination, we think of it is it rarely, but actually with the nowadays we have functional disorders very common, and rumination is also very common. So always ask the history whether the child tends to swallow back the vomiters. And I have many patients who will not give this history, but when you ask them then that history is forthcoming. Yes, they tend to swallow it back. So that is important. Secondly, what is very important is the duration after the meal intake. Well, if the child is just vomiting while taking the meal or just immediately after, so that is mostly food rejection by the child. So the gastric contents are digested, not digested, the time after the meal, the volume, and the other associated symptoms, that will help you decide.
So any child with the spit of the food just after the post feeding without any red flag sign, and after spitting child feeling the comfortable, it likely regurgitation. But if that incident episode occur repetitively with the other troublesome symptoms, definitely we should consider for the gastroesophageal reflux diseases.
One point I would like to add when Dr. Smita said about dental erosions. So a lot of the time we see a lot of toddlers having cavities, erosion. However, when as pediatricians we always think about bottle feeding. So sometimes when you look at the mouth of the child, you will not have a bottle feeding history, but if you look retrospectively or ask the parents, the child might be having some kind of gastro problems during infantile time in terms of persistent vomiting beyond 6 months, not eating well, having recurrent abdominal pain or diarrhea. So, so reflux contributes a lot to dental erosions in children, which we have not correlated so far.
Even otitis media, very frequent
Yes.
symptoms.
Dr. Meenakshi has asked, what is the minimum age for domperidone that can be given to it?
See, the guidelines say 12 years, but we are giving in all children. We are
Because
giving-
she's asking a GR in less than 3-month-old child.
So if you look at FDA approves it only after 12 years, but we are giving for even newborns. So practically we don't have anything. We don't use metoclopramide because of extramedullary symptoms, but domperidone we are using.
So can we use it for GR also?
Yes,
Like-
yes.
Sir, off-label we are still using, but definitely FDA is not approved for that. Other audience have the question, what type of the PPI is recommended in the early infant child?
So in infancy, the only PPI which is after 1 month of age recommended is esomeprazole. All the others are recommended after 1 year of age.
ठीक.
And many pediatricians are using ondansetron for vomiting. Is it recommended for?
No, it shouldn't be used. For reflux, ondansetron we don't. It doesn't have a role.
And
I think the best therapy is the domperidone.
Yeah. So you should always also remember that before putting the child on a PPI and a domperidone, a trial
Ji.
of amino acid based or extensively hydrolyzed formula milk antigen elimination in infancy is important, because CMPA in almost 15 to 20% children can be just because can present just as regurgitation. So that we should always remember. So what happens is most of the times it is just positioning, feed thickening, and then moving on to PPI and Domstol. That step of milk antigen elimination has to be done, and milk antigen elimination is not blanket. You after elimination you have to see it is a trial for 2 to 4 weeks. If there is no improvement in symptoms, then milk has to be reintroduced. So that is a step which is very important, that has to be considered. That is the management algorithm also for GRD in infants.
And Dr. Kurnal has asked, in pain abdomen, when we label it as functional, like after
If you
ruling
don't
out
have-
everything,
If you
or
don't have any
based
red
on
flags,
history.
if you don't have any red flags, so we all know the classic red flags, weight loss, anemia, bleeding, fever, any lower quadrant pain, like typical, you have it's a appendiceal pain, or you have in hepatic abscess, you will have a pain in the hypochondrium. So then so these are or you have a renal angle tenderness. So if you have typical red flags, you have weight loss, you have a child who is waking up in the night with severe pain, there is severe impairment in functionality. So these are the usual red flags which will tell you that no, you have severe diarrhea or you have bilious vomiting. So these are all red flags. If you have headache, so these are all red flags. And then if you don't have any red flags, you have a child who looks very well to you. If you parents don't tell you, or they don't come to you and say that the child has pain abdomen, looks like a very normal happy child, so in those are the children you will most likely to have functional pain.
We welcome
Thank
Dr. Ravinder Kumar, Treasurer
Yes,
cum
yes.
Secretary-elect IP Delhi, and Dr. Surinder Best, EB member from Delhi and President NNF Delhi.
I want to ask
Invest-
one thing, ma'am.
Mhm.
Yes.
One, if the baby is gaining a good weight and having this reflex, you can say, or the regurgitation of it, so do we still need a PPI therapy?
No, we don't. Reflux, reflux will, most of the children will outgrow reflux by 12 to 18 months of age. If there is
Okay.
adequate weight gain and child is doing well, you don't need to put them on any medication. So that
Because
is
many of times
GERD.
the
Treatment
parents
is
are highly concerned.
No, we don't have to treat GER. We have to treat GERD. So when we have GERD, then we will treat.
So if the troublesome
Okay.
symptoms
Thank you.
is present there, as we described in the earlier in presentation, only in that situation need the child workup, otherwise not required. And what are the investigation you not recommend to diagnose the GRD? Because many times in the OPD we seen the barium swallow study, scintigraphy. What is the value of this investigation as a being pediatrician?
See, mostly it's a clinical diagnosis. But as I mentioned in my slides, the sensitivity and specificity is low for ultrasound, barium swallow, GER scan, all these things. So only when you have GERD, you have typical symptoms, troublesome symptoms, only then you go for these investigations. For routine regurgitation in infancy, for routine spitters who are active playing babies, gaining weight, we don't need to do anything. In
So
a child who is small, like in infancy at 4 to 8 weeks, you may do an ultrasound to rule out a CHPS if there is significant vomiting.
So
Otherwise,
barium only if you are suspecting any complication like the stricture or post-F stricture or other anatomical detail.
yes, if you have
Or
post-esophageal atresia repair and all, in these patients or even in preterms, I think you or syndromic babies, in these babies you will have a low threshold of investigations, but routine,
not
normal
recommended.
well-growing
And
infants.
scintigraphy only for those are the children if you are suspecting the associated respiratory symptoms. In that situation might be contribute, otherwise not required the scintigraphy. That the best
For
way
how
of
long?
diagnosis as a clinical suspension along with some of the questionnaires proposed in the infantile age group, we can take the help by that questionnaires to make the diagnosis. Ma'am, nowadays, because especially in the newborn age group have the non-acidic reflex. So in that situation, how can we make the diagnosis? How can we handle both that biliary reflex or non-acidic reflex?
So for that, as I mentioned, manometric studies, the impedance studies are to be done. I am not doing it. There must be others who are doing it. It's not available, not very much available here. But for non-acid reflux, routine pH metry or the test which we do will not help. And I think acid suppression will obviously not help in these patients. So prokinetics might help. Feed thickeners and positioning might help. For feed thickening also, we have to understand one thing, that for breastfed children, the rice cereal feed thickening, they'll get digested by the amylase in the breast milk. So feed thickeners and exclusively breastfed children are also a problem. You might not be able to do it.
Yes.
Ma'am, does Indian tradition of baby cradle in neonate and infants trigger GRD?
Pardon, I didn't understand your question.
Ma'am, this question by Dr. Jignesh, like putting the baby in the cradle or maybe what?
No, I don't think. I'm not aware of anything.
Sir, if
Dr.
you are,
Shyam, what would you say?
they are saying that does any correlation between the position of the baby and GRD?
See, when you are supine, obviously, because the gravity factor is not there, the baby will the reflux will increase. So that is just supine, whether in cradle or on bed or any of the mother's lap, supine position will increase the reflux.
Ma'am, does any
Can
of the PPI trial for the diagnosis of the GRD? Because many our pediatric friends they said ki yaar, what is the role of the endoscopy? We just give the PPI trial. If the child is responded, then make the diagnosis as the GRD and we continue the PPI.
Only if there are very classic symptoms and you are very sure, otherwise that is not the right approach.
So
It
in
is
that
not do
situation,
it.
if the child have the classical troublesome symptoms,
Classic, yes.
along that if you give the proper dose for the proper duration, 2 to 4 weeks of the PPI, in that situation, if the symptoms is relieved, then you can continue the PPI for the 6 to 12 weeks.
Yeah.
In that situation, we can label.
It was there in the algorithm also, if you have very classic disabling symptoms in an older child, only in those patients.
So we have left only 2 minutes more. So
Hmm.
that's a lots of grilling of Dr. Smita
no,
ma'am.
we
And
can
One
answer
of
the
the
questions in
questions from the
the
audience.
one thing I want, one thing there are lots of questions in the chat box also, and I just say I can request the all delegates to put their question in the delegate group also, so they can be answered over there also, because for 39 or 40 questions, I think it's not possible for all of us.
They
So
are
So
we'll add
already.
Dr.
yes, sir.
Smita
Doc-
ma'am
Yes.
for 1 or 2
Doctor,
days in the delegate group so that she can answer them.
Majority of the
That is
questions
right.
covered by the Dr. Smita during the
Yes.
presentation. Ma'am, what is the role of the food thickener and what type of the commercial food thickeners available?
See, in India, what we are using, we usually use rice-based cereals which are available for food thickening. Other commercial thickeners, I have not used, and I don't think they are available. If anybody has any experience, I don't know. Maybe Dr. Sufla must have had experience when she was in the UK. In India, we use
Only
cereal
rice based.
rice-based.
Another thing I would like to add when Dr. Sham was asking about reflux. So, if you have given a trial of PPI, the child is not getting better, please remember the mimics as Dr. Smitha described. Eosinophilic esophagitis is very, very common in children, and unfortunately, it can only be diagnosed by endoscopy. So sometimes you will give a trial of PPI for 3 weeks, 2 weeks. Child get transiently better, but the symptoms comes back again. So it's very important, to rule out the conditions which can mimic and then treat accordingly.
So I request
Yes.
Dr. Ravinder sir to please say a vote of thanks, and we'll continue the question answer in the.
Yes, there is a sir, one minute. So this topic is a very vast topic, and that there are lots of questions from common pediatricians. Before that, I would like to take a one word from the Dr. Surendra Bist. Also, is the NNF Delhi president and the EP member of Central IIP from Delhi. Yes, sir, please.
Thank you, ma'am, and thank you, Dr. Smita. Shyam, it's a great initiative to start. And Dr. Ajay Dinesh, you have done a wonderful job. And thankfully, Pankaj, myself, and Mukesh Dhankar is reveling in the good work you are doing in Delhi. So we are getting the credit of whatever you are doing. I'm very thankful to this. As far as GER and acid peptic disease is concerned, in those days, madam, I was at Apollo and my son was a GER and we were just struggling to know that time. तब PPI भी 99 में नहीं था यूज करते थे बच्चों में. It was such a nightmare raising a child with GER and GRD that time because he was having respiratory symptoms also in those days. So I totally empathize with the people who are asking. It's the pediatricians who face that conditions again and again. And thank you all.
Thank you,
Before,
Dr. Bist.
before we close,
Thank
I
you,
would
thank
like
you,
to
thank
make
you, everyone.
Before we close, I would like to highlight one very important point that empirical and rampant use of PPIs just for normal reflux is to be strongly discouraged because PPIs have a protective role. And if you giving PPIs rampantly increases the risk of respiratory and bacterial infections, alters the gut microbiome also. So just judicious PPI use is important. That is the message.
Thank you, ma'am.
Thank
Thank you
you.
so much. Now, I would request our Treasurer, come Secretary-elect, Dr. Ravindra Kumar, to put vote of thanks for the all open.
Thank you, dear Dr. Goyal, and good morning to all. To a very winter, chilly morning. Still, all of you, I can see close to 200 people are attending this session. So, thanks to Dr. Shyam Meena for taking this the legacy forward and putting up this module. Thank you, Dr. Malhotra and Dr. Saxena, for a very interactive discussion. What we have seen. And after this discussion, I came to know that I was knowing very little about GRD. Otherwise, previously I was thinking I know a lot about GRD. So thank you for enlightening all of us, and I hope it's a very useful and informative for our in day-to-day office practice because GRD is a very common. So thank you all. Thank you all. Thank you, President Dr. Ajay Gupta, Dr. Bhandari sir, Dr. Vice President Dr. Sareen sir, everyone. Thank you. Thank you all.
Thank you, sir. Thank you.
Thank you, everyone, for
Bye
giving me
bye.
this
Thank you, ma'am,
opportunity.
for a
Bye,
wonderful
ji. Bye,
session.
bye, bye, bye.
Doctor,
Happy Sunday, everyone. Enjoy your day. Goodbye.
uh,
It's a
Dr.
nice
Dinesh,
sunny morning
kindly
in Delhi today.
kindly announce all the upcoming activities and Sushil display or last slide.
That is important.
So please register for Pediatric Conference North India being held on 20th and 21st of June at Hotel Lee Meridian. We'll be sharing the brochure in the delegate group. Please try to join us on June for a physical meeting.
ठीक.
Thank you, Dr. Gupta. Thank you all.
Thank you, ma'am.
Bye bye.
Rest of the question will take on the delegates WhatsApp group.
Okay, fine.
Okay, ji. Thank you. Thank you,
Thank
everyone.
you, sir. Thank you.
Alok
Okay.
bhai, thank you.
Thank you, sir. Thank you.
Bishji,
Nice seeing you Sunday morning, sir.
Shyamji, thank you very much. Yes, sir. Thank you.
Okay, ji. Okay. Bye, sir. Bye.